Good morning, everyone. Thank you for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by the Center for Substance Use Training and Telementoring, that's CSTAT. My name is Andrea Roche. I'll be facilitating our discussion today. We have a really great session lined up. I have some housekeeping just before we get started. As you might have seen, these sessions are being recorded for later distribution. So if you miss any content or want to refer back to this later, you can navigate to this video on the Be Well Texas YouTube channel. Also, these sessions are enabled for live closed captioning. If you want to view that, the closed captioning for this session, just navigate to the bottom of your Zoom window and select that Show Captions option. You might need to click on like a 3 dots or more menu at the bottom right corner of Zoom. If you're having any issues accessing captions, just chat with Kato with UT Echo IT and she'll help you out. People are already doing this, so I appreciate you for doing that. Help us with our attendance and record keeping by entering your name, your affiliation, and your email if you're comfortable in the chat. To access that chat feature, just go to the bottom of your Zoom window and click on that speech bubble icon. If you're a Be Well Texas provider, make sure you identify yourself during this session by sharing your information in the chat. And although I don't think anybody's done this, if you have joined by phone only, make sure you send that phone number to the Be Well Texas team at bewelltx@utesca.edu, the email you just saw in the chat, just so we make sure we catch your attendance. We encourage everyone to join by video, especially for the discussion portion in the later half of our session. But that said, regardless of how you've chosen to join us today, we're just happy you're here to learn alongside us. There are quite a few people in here, and that number is counting up. So please, just to make sure everybody has time and space to speak, stay muted unless you're speaking. Again, we do encourage you to speak. If you've joined by the computer, select the mute icon on the lower left of your Zoom window, or if you've joined by phone, you can press *6 to get audio privileges. Just remember that whether you're entering information in the chat, which you can also do to participate, or whether you're unmuting and speaking up, no personal health information is allowed in either space during the entire course of the session. Keep an eye on that chat window. Towards the end of the session, the Be Well Texas team is going to send out a link to a post-session evaluation survey. Fill it out for a few reasons. Help us to shape and craft these sessions to better meet your interests and your learning priorities. So give us that valuable feedback. This is also how we can provide CEs. So we're approved for continuing education units for paramedics and any public safety professionals with a behavioral health degree, like social work or counseling. If you're interested in other forms of CE, please enter that information in the survey so we can take that back to our planning team. And then last but not least, if you enter the survey, you're entered into a drawing to get a Walmart gift card. So please do share that feedback. Like I said, I'm really excited about today's session. We're going to start with a presentation from Dr. Jean Hearn on overdose receiving centers. And following that, we'll hear a case presented from the sector of community supervision and corrections. There are a lot of professions, a lot of sectors represented here today, and a lot of experience and perspectives behind that. So I encourage each of you to share those thoughts, those challenges, and those strategies during our discussion so that we can learn from each other in this space. ECHO is known for being a space where everyone learns and everyone teaches. So please do share your questions and your strategies today. Before we get going with didactics, we're going to do a quick introduction of our hub team and our presenters. I will start with you, Cynthia.
Good morning. Good morning. My name is Cynthia Mendiola. I'm a member of this program, and I am a retired federal probation officer. I worked with substance use disorders and mental health in the federal system, and currently I'm a trainer and coach for probation officers.
Glad to have you here. Jeremiah.
Hi, everybody. I'm Jeremiah Glocka. I'm the Executive Director of the SHIELD Training Initiative. We do occupational safety and health training for folks across the criminal justice, law enforcement, first responder system, specifically looking at issues connected to the overdose crisis. Thanks for being here today. This is going to be fun.
Thank you. Dr. Miramonte.
Hi, good morning. It's Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department. I'm a physician with UT Health San Antonio, and we do a lot of substance abuse evaluation, referral, and treatment. We do buprenorphine induction and get folks hooked into our community resources. So glad to be here. And we've got a good case today, actually.
Great, thank you. And welcome to a new member of the team. Julie, can you introduce yourself?
Hi everyone, my name is Julie Parrish. I am a new ECHO manager here at CSTAT with Be Well, Texas. A little bit of background. I am a licensed chemical dependency counselor and certified rehabilitation counselor by training. So I'm really excited to rejoin the ECHO world with you all.
Thank you, Julie. And Andrea.
Hello, everyone. My name is Andrea Hebler, and I'm the program coordinator for CSTAT. Happy to be here.
Thank you. Heather, we'll go to you next.
Hey, good morning. My name is Heather Gifaldi. I actually work for a judicial district that covers 4 counties in Southeast Texas. I'm a substance abuse counselor here, and I also am the safety coordinator, which means that I deal with our clients that have gone to safety treatment, which is treatment in prison, if you're not familiar with that.
Thanks so much for joining us, Heather. Really looking forward to the case conversation. Last but certainly not least, Dr. Hern.
Hi everyone, my name is Gene Hern. I'm a EMS medical director for a number of EMS agencies and the medical director for EMS Bridge.
Great, thank you. And with that, we'll turn things over to you, Dr. Hern, for today's didactic. Thanks everyone for joining.
Excellent, thank you. Let me share my screen real quick. It's truly an honor to be invited to speak to this group. It is, I have learned a ton from Dr. Miramontes in his various national presentations, and it's been a truly pioneering work that you folks have been doing in San Antonio. So it's really exciting for me to be a part of this session. So I'm going to talk a little bit today about what we have done in Contra Costa County in California. Contra Costa County is a county of about 1 million people with both suburban and some rural components as well. And so we're going to talk today about overdose receiving centers and about some of the things that we have implemented. My job in my faculty position is at Highland Hospital in Oakland, but much of my work here is related to what we've done in what was originally called California Bridge, and now is they're renaming to just sort of Bridge in general. But we're talking about sort of what the state of California has done in terms of increasing and incentivizing hospitals to be more aware of patients' needs who have an opioid use disorder or substance use disorder in general. So as I said, I'm the medical director for a couple public EMS agencies, Berkeley Fire and Oakland Fire, as well as medical director for a private EMS agency, GMR or AMR, in Contra Costa. And that's how this project located in Contra Costa, because I was medical director of the transport agency there. And obviously the views and opinions expressed are solely my own. Let's start with a case. Let's just imagine 2 a.m. 911 has just been activated for a possible overdose. A 22-year-old was found unconscious, recently released from jail. He regains consciousness after naloxone and reports that he feels like he's in opioid withdrawal and he wants to sign out AMA and leave. The question is, what resources can 911 paramedics offer this person? Obviously, this is a little biased because UT San Antonio has some tremendous resources to offer them. But let's just consider for a second the standard, which is supportive medication, maybe Zofran for vomiting and nausea, maybe some fluids, and offer them transport to the emergency department, where oftentimes they may self-discharge or they may leave against medical advice at the outset. So let's just consider what might be the gap in care at this point. Traditional care might be assessing, treating some, and transporting. But let's consider, if we want, for a second, a possible new standard where we assess them, we screen them for substance use disorder. We approach them from a more sort of motivational interviewing perspective, where we partner with the patient. We talk about substance use disorder. We potentially give them buprenorphine. We provide them with a naloxone leave behind kit. And here's the crux of it: we transport them to a hospital that is ready and willing and I won't say excited to receive them, because no hospital is excited to receive patients anymore. But at least the concept of like a hospital which is ready to receive them and has the resources there. And then a data handoff to public health and continued follow-up. So we're in this really funky position in history, right, where we have this massive and sustained exposure to opioids. And then we found this regulation and restriction without necessarily treating the dependency at the same time. And of course, we have this huge influx of organized crime filling the vacuum with synthetic fentanyl and methamphetamine. In California, we call it the white powders. Like there are 3 different white powders, right? There's cocaine, there's fentanyl, and there's methamphetamine, and sometimes they get mixed up. And we will oftentimes have patients who think that they're doing one thing and then end up accidentally having a fentanyl overdose and waking up saying, "Why are you guys here? I was doing cocaine." So it's the crossover is quite rampant as well. And we also know that the traditional models of care are failing to slow overdose fatalities. We know that the overdose fatalities in the US continue to rise, and we have this urgency to implement this care wherever they are, however they want it, and then link treatments to creating some sort of environment that improves survival. We know also that if you survive an overdose, you actually have a fairly decent chance of dying in the next year, right? So 1 in 20 patients who survive an overdose will die in the next year. And remember, these are young patients, right? In general, the demographics age, 18 to 45. And that is a lot of life years ahead of them. If you survive a heart attack, your chance of dying in the next year is not 0, but you're also, potentially much older than the demographic we're talking here. But what's also crazy is that we find that of the people who die in the first year, 20% of them will die within the month, and a fair number of those will actually die within 48 hours, which is super remarkable. I mean, the idea that somebody is seen in an emergency department, goes home, and then in the next 48 hours has a significant risk of death from the same thing that they were just seen for. And that is actually pretty remarkable. We also know that if a patient is not transported after they get naloxone, they actually have a fairly high risk of overdose in that category. So the patients who refuse transport have a significantly high rate of overdose subsequently. What's also true about EMS is that EMS has, the ability to see these patients at risk. So it turns out that like a non-fatal overdose is actually a really strong predictor of a future fatal overdose. When we look at EMS records, San Francisco Fire, for instance, of the people who suffered a fatal overdose, they saw 50% of them in the prior year. So 50% of patients who died in the subsequent year, EMS saw at least once. So is there a chance for screening? Is there a chance for some sort of other intervention? And we know that paramedics are at the scene of this disaster. And this is potentially an opportunity to affect not only patient care and patient outcomes, but also our workforce. We know that our workforce is suffering from burnout, lack of resilience, seeing the same, going to the same houses for overdoses, and seeing the discarded bag valve masks in the corner that they were there for a week before or 2 weeks before. And so knowing that getting patients into treatment gives them a chance at survival, then this also affects our workforce as well. So let me talk a little bit about what we did in Contra Costa and a little bit about the concept of an overdose receiving center. So what we did was we actually were brainstorming about patients who never made it to the ER. We had a low threshold ER experience at Highland in Oakland, where patients who came in and said they had an opioid use disorder were sort of fast-tracked into getting a prescription for buprenorphine, getting a clinic, getting a follow-up within the next 48 hours. And that was a really great sort of low friction access point for those patients, but they had to be in the ER already. So we were wondering about all of those patients that potentially signed out against medical advice. Like there's a ton of patients we think that, some places have a super high AMA rate, 50%, 70%, where they have an overdose, then they wake up and they're like, no, I'm done. Don't transport me. I don't need to go to the hospital. I get those looks. People don't want to take care of me, and I'm going to stay here. And so there's this sense of potential patients that are being missed. So we sort of brainstormed with it.
Did others lose audio for Dr. Hearn as well?
Yes, ma'am.
Oh,
Can you hear me?
yeah, it was just the last sentence or two, but we can hear you now. Oh, and we lost it. We lost you again, Dr. Hearn. Still, we lost you again. Not sure what the modification was. Dr. Hearn, are you able to hear me? Sorry, I'll give us a second while we troubleshoot this. I'm gonna try muting. We'll try that one more time. I need to interrupt screen share. Dr. Hearn. Kato, would you mind just stopping the screen share for a second? Oh, there we go. I think I got his attention. We lost you again. I'm telling you, Zoom just updated and we knew we can't hear you. Still no? Yeah, you might want to try switch. If you were on a headset, maybe try switching to just plain computer audio. Yep, say a few more words though.
Absolutely. Double checking that you can hear me now.
I can hear you now. And yeah, we stole your screen share. I think it was about a slide's worth of content we might have lost from you. So if you want to re-screen share and take it back, sorry to interrupt you like that.
Not at all.
And thank you all for your patience while we figure that out. Perfect.
Exactly. Okay. And so the concept is we figured out a place where we were missing patients. Let's figure out a place that EMS can have a role in treating these patients. So EMS typically has a binary response. You call, we haul. Like you call, we'll show up with 5 people and a bunch of equipment, and we will take you to the hospital if you would like. But there's a lot of different things that EMS potentially can do in sort of all over the country. And these are examples of things that are already happening. You could screen patients, you could give them resources, you can create a safe drug drop scenario where patients' families can drop off, old medications that were for their cancer patients or whatever that they don't need anymore, that they're pain meds, and they can drop them off in a safe, like pharmacy type of lockbox setting. You can do education, referral. You can distribute first responder Narcan. You could actually potentially even do like fentanyl test strips. And then those are all things that can happen before an overdose. But then there's the overdose. But then what can happen after an overdose? So one of the concepts that we developed was the idea of an overdose receiving center. And we'll talk about that in just a second. We also had a warm data handoff to public health after the 911 call happened. And then there are places that actually do mobile integrated teams. They can have a home visit. They can go to the patients, after their ER visit for follow-up, for giving subsequent doses of buprenorphine and that sort of thing. And then, of course, the paramedic-initiated buprenorphine, which, of course, UT San Antonio is all about already. So the concept of an overdose receiving center, this was something that we thought, isn't it interesting? We have spent a lot of resources in many years developing very excellent models of care around trauma centers and around stroke centers and around STEMI centers, where you have locations where incredibly high-risk patients will go to where there are specialized facilities specialized training, access to, different individuals that may have, again, specialized knowledge, and the ability to treat these patients and potentially give them a better chance of survival. So that's all of the data around trauma centers and STEMI centers, et cetera. So why wouldn't, if it turns out now that more people are dying from overdoses than they're dying from gunshot wounds, on a per capita basis, or motor vehicle accidents as our cars have gotten safer, why wouldn't we create hospitals that have personnel trained and ready to receive these patients to give them the best possible outcome? I mean, that's the entire point, is to have these patients have a good outcome. So wrap around resources at regional sort of strategic emergency departments, and then designate them as a overdose receiving center. This is sort of a funny, it's like a stroke receiving center and a trauma receiving center. The concept of an overdose receiving center was a little like grandiose, perhaps, but the concept is there, and the data is there. So let's talk about what that actually meant as an overdose receiving center. So our bridge model was basically that we designated bridge hospitals throughout California, where they had clinical champions, they had a substance use navigator that could provide education, support, and linkage to ongoing treatment. And the patient gets evidence-based care. So the original model of the bridge hospital in California was that all of the ED staff were X-waivered, and that they were familiar with buprenorphine, familiar with treating patients who had an opioid use disorder. And that was the main concept. But so we implemented this. We designated the county hospital in Contra Costa as the overdose receiving center. And then we implemented the 4 things that we implemented, which was overdose receiving center, leave behind Narcan, paramedic administered buprenorphine, and the warm data handoff to public health. And what's interesting is that we tracked these patients to see how they did over time. So what was their 7-day follow-up rate? What was their 30-day follow-up rate? And it turns out that when they went to a overdose receiving center, or the bridge site, they actually had better follow-up rates. So this was our data after our first 87 patients, where in all of California now we have about 130, I think. But this was the initial one. And if the percentage is really the key, and the 7-day follow-up is the sort of steel blue color, and the 30-day follow-up is the light blue color. But if you focus on the 30-day follow-up, it was the number of patients who had decent follow-up was really quite high, as opposed to the other hospitals. So other hospitals had it was like a 25% follow-up rate, but the 45% of patients who actually went to the bridge site had a 30-day follow-up, which is pretty remarkable. And there's something about that receiving center or that bridge site that meant that the patients were talking to people who were comfortable talking with them, taking care of them, offering them prescriptions for buprenorphine, and getting them into our access points. And that was really, really the key. I have to talk a little bit about our other 3 interventions briefly, just because we're not sure which intervention made the most difference, but this data suggests that the retention rate by transport destination was at least significant enough for us to continue this model and then advocate it potentially at the state level. We also did a naloxone distribution project where the state of California actually had a grant process for naloxone kits. And so we distributed this to many of our patients. They didn't actually have to be patients. We could distribute it to people we thought were at risk, or people who walked up to the ambulance and said, "Hey, do you have any Narcan?" So we actually have given out like 500 doses of naloxone as well. We, of course, have the paramedic administered buprenorphine. This project is based on a 911 paramedic model. So all 911 paramedics in the system, in the transport agency ambulances, have buprenorphine on the rigs. We give buprenorphine for opioid withdrawal for any indication. So the Camden model is where they can only give it for post-naloxone opioid withdrawal. We have allow that for both post-naloxone or naloxone precipitated withdrawal or abstinence withdrawal, or even like the potential case of where they take a small amount of bupe and they have bupe precipitated withdrawal, we would probably authorize entry into the program for that as well. Again, it doesn't take any additional staff. There's a pretty simple algorithm, and we have basically a base hospital consult that the medics do to confirm the case. You can QR code our protocols, but this is basically the bridge site protocol for EMS for opioid withdrawal. And basically, if you have a COW score, you have some inclusion and exclusion criteria. COW score greater than 7 could get you entry into the model. Here's a slightly closer up. If you have a COW score greater than 7, you can get entry and see if the patient is interested. If they are, then they can call the opioid protocol physician or the base hospital and get approval, and we give them 16 milligrams sublingually, and then we repeat that with another 8 as needed. The fourth thing we did was we integrated the system where we have a data handoff to the public health substance use navigator. And this is sort of an interesting thing, which was constructed so that the paramedics didn't have to do anything extra, because we know that like when you put in further administrative bars or hurdles, our field providers may or may not be as willing to implement that protocol as they might. So the paramedic provided care, the medic documented it in the electronic platform, and then there's this program called FirstWatch, which is sort of around, it's all over the US. I think they cover about a third of all EMS agencies. And FirstWatch does a data watching and data dredging of your protocols to make sure, of all your patients, to make sure patients who have chest pain are getting aspirin and EKGs and that sort of thing. Well, you can set specific parameters. And so we created a parameter or a trigger for an overdose case. So anytime we have an overdose case, we get a FirstWatch trigger that sends an email to our public health substance use navigator, and they get those trigger and they can access the patient information once the PCR is done. So they can follow up even if the substance use navigator isn't on at that moment. It's 2 a.m. on a Sunday morning, and our substance use navigator isn't in the ER. They can access the patient's chart on Monday, call the patient, reach out to the patient, see if they got a prescription, or see if they want a prescription, or if they need to get into clinic. And this warm handoff is allowed in that our EMS agency is sort of under the umbrella of both the Department of Healthcare Services in our county. So it has the public health department as well as the county medical center and EMS. So the EMS patients again are flagged, and navigators then provide follow-up. So let's look at our impact so far. We've had over 1,000 since the implementation of the project. We've had 1,000 potential overdose triggers. It turns out that a lot of the patients still are a little too altered to participate in that process. So it turns out only about like 14% or so are eligible. We feel like they'd be good candidates, and then just over half of those actually get treated with buprenorphine. They either refuse or for whatever reason they're not interested. But in the end, it turns out that we've had decent numbers so far, in that just under 30% of our patients have continued in treatment at 30 days. And I think that's really important because, I mean, remember, these are incredibly high-risk patients. It's a high-risk population. And so to be aware that that's the case. So 30% at 30 days. We've noticed of all of our cases, 3/4 have had a decrease in their symptoms, and the other quarter really hadn't had any change. We've had no cases of precipitated withdrawal in Contra Costa. We've had one case in San Francisco. They just started a couple months ago. And a few patients have been admitted, but none have been related to their opioid use disorder. And finally, we've seen a pretty decent uptake, especially in the African-American population, which we found pretty significant. And then the data out of Cooper, I know I'm running out of time here, but the data out of Cooper also suggests that they're doing similar with an outpatient follow-up rate of 40%. And 50% of their patients leave AMA, but yet they still have a 40% follow-up, which is truly remarkable. And our patients seem to have benefited from this intervention. So this patient who said that it really helped a lot. It was getting back to normal. And I got more Suboxone once I got to the hospital. I'm now a student at UCLA. So it's really helped me to be more stable and stabilized. The final takeaway is that MAT in the field is safe and effective. ORCs in this model, or the overdose receiving centers, seem to have an oversized impact on outcome. And that's the main reason why we're continuing it. And where we implement this protocol in other places throughout California, the implementation model is to send these patients to a bridge site if they are willing. We don't force patients to go, but that's the plan. Thank you very much, and I welcome any questions.
Really great presentation, Dr. Hearn. Thank you so much. Yeah, any questions about this presentation? If those,
I got one. So how did you get funding and buy-in for the hospital to do that?
Great question. I think the main reason is that the hospital, because it was the county hospital, it already was sort of under the auspices of the Department of Healthcare Services in the county, and they were already pretty dialed into the county clinic system, and so I think that made the difference. Like, it's a very because it's a safety net hospital, they're like, we see a lot of these patients anyway, and they were already getting funding from the bridge side. And so we just said, you're already going to see a lot of these patients. I don't think they were offered any additional funding, but they were sort of in the good graces of their administrators higher up.
great question. And we have another from Amy in the chat. If you can review the training provided to paramedics for BUP induction. Then
So the initial, it's changed over time. Our initial training was a 4-hour in-person training. And then that actually, we've now whittled down. So we have it under an hour in a video format. Actually, we have Bridge has like a YouTube channel that we share with the counties that are starting to implement. So it's basically 58 minutes. We divided it into just over 20 minutes about sort of the opioid crisis in general, and about, harm reduction, treating patients where they are, and a little bit about sort of judgment. Absolutely. So I think that's really, so getting it down was really key. So one of our docs out of UC Davis is a great speaker, and she really talks about sort of harm reduction and the approach to patients with an opioid use disorder. And then then we do a section on motivational interviewing. I do a section on the protocol itself, and then we do some cases where we talk about CAU scores, and we've narrowed it down to 58 minutes. So for our counties that are implementing, and we're implementing in about 6 other counties in California right now, they do that training, and then they do their own, like, how it's going to be, stored in their NARC box and what their operations system is going to be like. But it works really well. What training goes into creating an ORC, especially with changing attitudes towards being Yeah, so great question. The ORC, or the bridge site, is really the training happens at the hospital by the substance use navigators, and so it's making sure that, so they're also, you have to have a clinical champion who's a member of the ED, like emergency department group, who is willing to sort of address it at their department level. And then, so it's a sort of a tag team. There's the emergency department clinical champion that addresses it at the provider level. And then the substance use navigator also reaches out to nursing and admin and helps with coordinating into clinic.
Great. Well, we'll do one more question because it's a doozy of a question from Kim here. If you can speak to creating a consortium to bridge services with law enforcement, EMS, and SUS outpatient services, and we'll go from there to our announcements.
Totally. I mean, I think that's really the secret sauce, right? I mean, it's really the key. And for I'm sure you're familiar with OD maps, but our one of our implementation partners in Monterey and Santa Cruz, they actually are super engaged with OD maps and tracking like overdose hotspots. And then, the key is also having you have to have access to your outpatient clinics and outpatient centers in order to maintain and to create that ongoing treatment. Because giving them bupe in the field, while that's very sexy, it doesn't do anything for the long term. It's great for the first 36 hours, but it doesn't do anything for the long term. So the idea would be to have, you have to have a clinic model in place to get those patients access. And so that is truly the key. And what's really interesting is that there are some models where there's a response team that goes to the patient's house the next day. And that response model, like Coleraine Township in Ohio, is a great example of that. And that response model has law enforcement, has social work, has an EMT, and has a peer counselor. So 4 people show up the next day and say, look, we're here to help. We get you into treatment. And it's that sort of that collaboration with, yes, EMS, law enforcement, and social services that helps sort of foster the sense of like, hey, we're all in this together. Our people in our community are dying. What are we going to do about it?
Great. Thank you so much. Great question, Kim. Well, if you have more questions, just throw them in the chat. And Dr. Hearn, I'd ask you maybe to respond to them in the chat, or if we have time in the discussion portion. Let's move to some announcements from CSTAT. So if you're unfamiliar, the Center for Substance Use Training and Telementoring provides high quality education in best practices for responding to substance use. So CSTAT can help enhance professionals' knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, visit this team at c-stat.utesca.edu. We'll put that over in the chat. Next slide. It is time to renew this series. This is something we do once a year, so please bear with us through this so that we can continue to see all your wonderful faces at our future sessions. To make this easier on everyone, CSTAT is just extending this meeting series rather than making you all re-register. So you should have all received an email with some instructions and a separate notification email from Zoom. All you need to do is add the series back into your calendar. Again, we're only going to do this once a year, so just bear with us through this little step, and then you can keep on coming to these sessions. Next slide. Speaking of, we hope you will join us next month on September 14th and with a didactic that's going to be focusing on promoting collaboration between the police and the community. Thank you, Kato. You can stop the screen share. All right, at this point, we're going to get over to our case presentation. Heather, once Kato shares the form that you submitted to us, please take it away, share a bit about this case, and then the questions you have for this learning community.
All right, great, thank you. So as I mentioned before, I work for a probation department. I have plenty of experience in the private sector, and I feel like I'm still learning how to work at probation. I've been here for about 5 years, and it was shocking as a clinician, although I was aware, to realize that my clients ultimately, their ultimate consequence for relapse was going to be prison, right? It was going to be revocation of their probation. Substance use is a violation of their probation conditions, right? So the thing we're addressing today is addiction is a disease, as we know. Should someone be punished with prison if they relapse, right? That's a big question. For me, it's how many opportunities should a person on probation be given? And ultimately, I work with a team. How do we enforce probation conditions while still aligning with the disease model? I have a number of people here, mainly in our area. The substances we deal with is methamphetamine, alcohol, and it was also kind of surprising to me because I came from a city where the main thing I dealt with was opioids, is I'm also dealing with a lot of people with a cannabis use disorder. So I chose one case that kind of follows a lot of cases that I deal with, but I worked with this gentleman for years, which turned out to kind of be some conflict between me and his supervising officer. So he was placed on probation for an assault charge. He had a history of twice assaulting his father as they got in arguments over whether or not he was going to use keys to the car. And so he was placed on probation for assault of an elderly person. And he had multiple relapses while he was on probation, right? He was placed on a 10-year probation. This is the longest probation you placed on in Texas. And while he was on probation, he had a relapse. He was placed in SafeP. SafeP is a 6 to 9 month long treatment in prison, where they then go to a couple of months of a residential treatment, and then they have 9 months of outpatient aftercare. So it's pretty extensive. He made it through SafeP successfully. He made it through residential successfully. Matter of fact, he was exemplary in those programs. He did extremely well in aftercare. It was what happened after he was done with treatment. He experienced multiple relapses while he was on probation after treatment. And his officer had said, you know, he's violated these probations, he's had treatment, what else is he going to learn from treatment? He should, you know, go see the judge and deal with the punishment. I was continually advocating for additional treatment for this individual. After he experienced another relapse, it was a brief lapse. We did IOP. We had him do a supportive outpatient for another 6 months. A third relapse resulted in going into what was called an intermediate sanction facility, which isn't in a prison, but it's still ran by a probation department. And ultimately, there was another relapse that resulted in his probation being revoked, and he was sentenced to prison. What we ran into was he did very well in the treatment setting. It was, you know, what was happening as far as recovery behaviors outside of being in treatment. He had been in treatment a lot. And he knew the lingo, right? There's a level of fear when it comes with probation that I talk to my clients about, you know, be as honest as you can be in this setting. It's an interesting setting where you know that there's a good portion of what you're being told is not true, even when they want help, right? Even when they want help, there's a certain amount that's not true, because this is probation. You can go up a little bit on the slide, or down, whichever direction. There you go. Like I mentioned before, he's had multiple cases in the past. He's been on probation multiple times. He has been involved in the law enforcement system for quite a while, with probation for quite a while, and it's all been alcohol related. And so I was troubled at the end of working with him, because this was everything that he got into was always alcohol related. There weren't any cases that he received that were outside of his substance use disorder. So, you know, the question was, you know, were we providing him all the services possible, right? You know, at what point do we stop treating his alcohol use disorder and start treating it as a crime? Because he was getting treated with both at the same time, right? You know, we can force them to go to treatment. We can't enforce recovery behaviors outside. We did have poor follow through, you know, start off strong and kind of taper off, which, you know, is common for everyone. That's not just someone that's on probation. Like I said, he did very well in treatment. Some things that I've learned from this is just, how do I monitor more? And I hate for it to be monitoring. It's more about enforcing these recovery behaviors just in a way of, even if they're not doing it, even if they're telling me, oh yeah, I'm doing all these things I'm learning, is to remind them on a regular basis of what they're supposed to be doing. Like if they have to look at it on a daily basis, something's going to stick, right? So, started having, our regular clients, do weekly logs. They have to tell me what exactly they've been doing. Now, I look at some of them, I know they're completely made up. But what I tell myself is they are aware. They're aware of what these behaviors are, whether they're doing them today or not. They're going over them over and over again. They're aware of what their recovery behaviors are. So if I see them again after a relapse, we can go over and I can say like, now really, like what are the recovery behaviors you could put in place? To find success with, at minimum, we're looking at someone to complete probation successfully, right? Our job in probation is to keep these people from going to prison, right? And ultimately for the individual to change their substance use to reach the goals that they want. In probation, we're telling them you cannot use any substances. We know that that's not everyone's personal goal. And sometimes their personal goal is, I just want to, not use as much, or I want to do better. Obviously, they can't use while they're on probation, but we don't want to see them back for charges received from substance use disorders. If y'all have any questions about what all those treatment modalities are as far as probation, I can answer those. They're definitely different from, the private sector.
Well, Heather, my name is Cynthia Mendiola. How are you doing? I know you're in a difficult position because you're a counselor working with these individuals, and you're having to deal with staffing and meeting with probation officers and trying to give them an understanding of where this person is at and what are some things that person needs that obviously is becoming in conflict with what the probation officer is supposed to do with the courts. And I know that you're in a spot that's just really, really difficult, because what's happening is that you're coming from one end, they're coming from the other. And what I think that really needs to happen in this situation is that probation officers are the first people they're the first line of defense for these individuals not to go back to prison, right? And if they're going to be the first line of defense, they need to have an understanding of what the substance use disorder is about. Why is it that people don't, sometimes a relapse? Why is it they don't do well in certain programs? And probation officers have to have a good understanding. And I'm not saying this just because I think that's what they should do. That's what I did as a probation officer. They have to have a good understanding of again, the substance use disorder, and what are some things that they could bring the law to meet the counseling halfway, find ways around, I'm not saying manipulating the law, but fitting the counseling and the substance use disorder within the law enforcement system. And it can be done. I've seen it. And so I think that it has a lot to do with education and training.
Yeah, absolutely. Thank you.
Great guidance and encouragement, Cynthia. Yeah, Dr. Miramonte, see your hand.
So I'm listening to this case and I'm saying to myself, why hasn't this guy been offered medication assisted treatment like naltrexone therapy, antabuse, whatever? And I'm just thinking to myself, from the medical side, why is we've tried all these different treatment modalities, but I didn't hear anything about medication assisted treatment. I didn't hear anything about a psychiatric assessment. Does he have childhood sexual assault trauma? Is he self-medicating with alcohol because he can't sleep at night? These are all things that come to my mind. And I'll be real honest with you, a lot of my patients that are dual diagnosis, they're using alcohol, meth, or whatever to try and offset the negative symptoms of their underlying psychiatric illness. For example, my schizophrenics use meth because it makes the voices go away. I have patients that use alcohol and they drink until they pass out so they can sleep. We have patients that use benzos or alcohol to treat their underlying anxiety disorder that maybe in a medical model could be addressed. What's frustrating to me is this guy has gone through all these different treatment processes and we keep doing the same thing over and over again, but not flipping the switch and say, so what are we doing wrong here? Maybe there's something that we're missing. Maybe there's meds, maybe there's psych, maybe there's trauma we haven't addressed. So that bothers me. Now, on the other hand, I'm with you. This guy has some very dangerous behaviors. The DUI, he's going to kill somebody. He's got an assault on the elderly family member. Very dangerous. So we have to balance this risk of behavior and risk and what we can treat with a medical model, a behavioral health model, a cognitive behavioral health treatment model, a 12-step model, a faith-based model, or whatever model works. Or maybe it's the combination that's going to work for this guy. But substance use disorder is a chronic relapsing disorder. It's a brain disorder. So we need to make sure we're attacking it in different modalities. So those are kind of things that came up. Medical model, psych, what's his behavioral background? Does he have trauma? Have we done trauma-informed care type approach? Or are we just throwing this guy in jail to keep him from hurting somebody?
Thank you, Dr. Miramanos, and I appreciate you bringing that up. He was being treated by our local LBHA, which does not, by the way, offer medication assisted treatment for anything, for any substance use disorders. He was attending, he was receiving some medication for anxiety. He suffered from anxiety a great deal. And yes, he did have some childhood trauma that was being addressed as it could be. He was not as compliant as I would have preferred for him to be with going. Anyone that has experience with no cost psychiatric services knows that it's a frustrating process, the walk-in process. But yeah, there are not in the legal system where we're at services as far as medical services for any of our clients.
Yeah, and so if you compare that, so you're a diabetic that comes to the ER 6 times in a year for his glucose being high. So you're just going to tell him, okay, so don't eat donuts, don't eat Twinkies and Garbs, and you'll be fine. Okay, so that's ridiculous, right? You think that's just stupid. We need to get this guy on metformin, have him see a dietitian, get his blood pressure under control. He needs to lose weight and exercise and primary care follow-up, right? And it's the same for your client. He needs that other side that he's not getting. Now I understand why we have a failing. This guy has got underlying anxiety trauma and he's got an anxiety disorder. What makes anxiety go away that you can get down the street at any corner store? Booze. You get drunk and your anxiety goes away. It works in the same GABA receptor as a benzodiazepine, and he gets treatment for that. So he's tuned in to what he needs. We're just not giving it to him. And so he's using alcohol instead. Shame on us.
I totally agree. I think that it's also the probation officer's responsibility not to just ferret an individual to a provider, but to be in touch with some of the issues that Dr. Miramanos is talking about and making sure that when you do make those referrals, that they're appropriately done. It's also on the part of the officer.
And I'm going to bet that he is not insured because of his issues.
Correct.
Which is even worse.
Yeah, he's not insured, and we are a rural area, so there are not. Actually, for someone with insurance, there's not a psychiatrist in all 4 counties that I work in. That even takes cash or insurance. It is only the it's called Tri-County Behavioral Health. It was an MHMR at one point.
Really,
So-
really great. Oh, go ahead, Dr. Marimonti.
Say perhaps our friends at Be Well Texas can be of help. They have it's statewide, no low barrier. They do offer options for alcohol treatment. So that might be a resource for them. And they can do telemedicine with a cell phone. Well, there you go.
Great conversation. I know we're coming up on the end of the hour, but I'm getting reminded of why I love ECHO so much. We've heard this perspective from corrections and Dr. Miramonte chiming in from medicine and Sean bringing in the recovery perspective as well. I wonder if you might unmute Sean and just share a little bit about what you listed there in the chat. We might have lost him. That's all right. It's pretty eloquent in the chat itself. Kim, you shared a bit in the chat too about sort of shared experience, shared similar clients. Oh, thank you, Tricia, for the note about Sean. Was there more you wanted to bring to the group? Some questions? Yeah.
Are you asking me, Kim?
Yes. I saw you'd listed some experience in the chat.
Yeah. So just, coming up with every possible way to help somebody who's a constant relapses constantly with alcohol and loves the material we go over together, the psychoeducation material. And the main trigger for this person to relapse is spousal abuse, mainly verbal. And I even have one of my coworkers gave me this book. It's called The Verbally Abusive Relationship. I don't know if you can see it. Oh, wait, hold on. Anyway, it's called The Verbally Abusive Relationship, How to Recognize It and How to Respond. So, it's all that trauma that people have that in many places, they're just seeing the person, behaviorally and they don't really address the trauma. Like, can you cut down on this many beer, whatever it is. So that's wonderful, but I do all of it. I try to do all of it to support those people.
Thanks so much for sharing, Kim, and for the resources as well. Any other thoughts for Heather on this case?
I just want to say this is a classic example of like a super high risk individual on so many levels. And I think that's, I'm glad that we're recognizing like the importance of having resources from a bunch of different directions to try to address that. Because as Dr. Miramonte said, like, if this patient was at risk from a purely medical disease, there'd be a lot of different attitudes. But the fact that this encompasses both psychosocial and psychiatric, as well as the overdose, the substance use disorder, it's an incredibly complex web, and just the overlay of the DUIs and the danger makes it super, super hard. And I'm really glad that you're having that discussion.
Thank you, Dr. Hearn. And just a couple notes in the chat about maybe seeking out recovery services or asking if there's a peer with some lived experience who can provide some support. Well, we're coming up on the end of the hour. I'm going to turn to Cynthia for a summary of key points from our conversation today. Cynthia, when you're ready.
Yes, I think that it's, I think what's recognizable is that we're still having, communication issues, training issues, things that are lacking to bring the criminal justice system together with the substance use disorders and mental health issues so that it doesn't conflict with the law. And I think that it's really important that we need to have more and more training and coaching of officers, which we do. We're trying to do that, but to have an understanding of what these diseases are and how we can overcome some of the rules, some of the laws, some of the conditions that don't make sense anymore. I mean, those conditions are obsolete, they're old. Telling someone don't use when they have a substance use disorder, conflicts. It's a conflict. So I think that it's important that we were also recognize there's a lot of resources that are missing out in the communities, especially some of the small counties, that we need to have more and more communication about where those services can be found.
Really great summary. I want to thank you all for joining us today. Dr. Hearn, thank you for the inspiring and informative didactics, and Heather for bringing us such a challenging case that pushes us to think about how we can support individuals, especially when they're working within systems that don't. Thank you to all of you for showing up and bringing your experiences and your questions to today's session. As a reminder, make sure you add this series back into your calendar from that Zoom notification email. Kato has helpfully put that post-session survey link a couple times over in the chat so you can access that. We'll see you in a month on September 14th at 11 a.m. Central. Have a great rest of your day, everyone. Bye-bye.